All right, well, I think we can go ahead, and if people are, trickle in midway through, that'll be just fine. First of all, welcome everyone. I'm Ann Vanderkamp. Thank you so much for taking time out of your, what I'm guessing are very busy schedules these days, to join us for a discussion of the impacts of COVID-19 on the healthcare industry. We're looking forward to a great discussion amongst this panel of esteemed IWIRC members who also have significant experience in healthcare bankruptcy and restructuring issues. So over the next 60 minutes, we plan to discuss the state of the healthcare industry pre-COVID-19 and the current and long-term implications of this crisis on the healthcare industry. So as I mentioned, my name is Ann Vanderkamp, and I'll be moderating today's discussion. I'm a principal within Baker Tilly's consulting practice, and I specialize in restructuring and complex litigation. I'm typically retained to provide financial advisory, litigation consulting, and investigative services in distressed situations, typically involving allegations of fraudulent transfers or in post-bankruptcy fraudulent transfer litigation. Also, outside of distressed situations, I also provide expert testimony regarding the calculation of damages in complex commercial disputes. And now we can introduce the rest of our panel. We can start with Genevieve.
Hi, thank you, Ann. My name is Genevieve Weiner. I'm a bankruptcy and restructuring attorney with Sidley, Austin. I've been with Sidley for about a year. I was with Gibson Dunn for 12 years or so before that. And I'd say I have a generalist restructuring practice, which has included representing hospitals and other healthcare providers, as well as medical device companies, as well as a whole host of other industries. And it's great to be here. I was the past co-chair of the IWIRC SoCal chapter, SoCal network, excuse me. So I always enjoy doing IWIRC presentations and panels. Thank you.
All right, Karin.
Yeah, my name's Karin Berg. I am a bankruptcy and also finance practitioner at Blank Rome. I, similar to Genevieve, have been at Blank Rome just a year, moved over last June, so I guess it's been a little bit longer than a year, but was previously at Cat & Mushin for 13 years. My practice focuses on quite a bit of healthcare in terms of representing lenders and all types of industry participants in the healthcare industry, and including various types of loans from unsecured to secured to real estate throughout the healthcare industry. So similar to Genevieve, I am actually the immediate past chair of the IWIRC Chicago network, and I'm my IWIRC friends and enjoy being on this panel too. So thanks for the invitation. And I'll turn it over to Margie.
Thank you, Karin. I'm Marjorie Kaufman, and I'm a managing director at Getzler Henrich in Boston. I've been with Getzler Henrich for almost 15 years, and I won't say how long I've been in the restructuring world because I think it's probably longer than I won't say it anyway. I work on various an array of industries, including healthcare, and working with companies mostly. Helping them get through some kind of transition, whether it's a bankruptcy or an out-of-court restructuring. And Michele.
Hi, I'm Michele Michaelis. I am a managing director at BDO USA in New York. I will say I've been with the firm for a quarter of a century and doing I've done restructuring for about 20 years. I've worked historically as financial advisor to the unsecured creditors committees, as well as doing certain debtor work, as well and some litigation support and/or solvency or forensic investigations. I have a background with a broad range of committees and have worked with SNFs, elder care, and hospitals. And I thank the IWIRC organization for inviting me to speak today.
Well, great. We're so happy to have you all joining us today. So we could kick things off with talking a little bit about what trends or stressors were you all seeing that were impacting the healthcare industry pre-COVID?
So first of all, we've in the deals that we've been seeing, a lot of the industries within healthcare are fragmented. There's lots of, especially on the physician's practice and the dental practices. I know people don't think of dental as being healthcare, but obviously it is. Lots of failures, if you will, even before COVID hit. I'm not sure if people thought that they were just going to roll them all up and have these very large practices. I worked on one a couple of years back, and it was crazy. I think that they get a little bit overzealous on what they think that the practice is actually going to do, and they build overhead similar to any other industry, but they tend to build overhead. I think also because of shift in reimbursements and reduction in reimbursements, they were suffering, as well as the hospitals. And we've all seen, prior to COVID, probably in the last few years, there's been a whole bunch of hospitals that have failed, even, without all of this craziness. And also there's been a whole bunch of M&A, transactions out there because of the failures. And in some instances, and obviously you need to look at them, some of them don't need to be open. There were excess beds out there. That's what we were seeing.
Yeah, I second that. I can also say that in my mind, and I think the way we approach, having looked at the industry for a while, the shift from your traditional old-fashioned, you had your family doctor and that you just trusted them, they told you this and that's what you believe because you were going through, it was almost years ago, the whole idea of the joking of bartering, a chicken for, a doctor visit. Now, since so many people are covering their own medical costs, or such a significant part of it, quality and the feel you got from a doctor's office or from the hospital, or, the idea of bedside manner suddenly became so much more critical that you do have a different, it went from being a service that you just kind of, the healthcare industry went from an industry that people just kind of believed in because that's what they were told to believe in, to, well, who's going to give me the best price for what I need, and I don't need more than, and at least that was, that's our take on the whole pre-COVID environment.
Right, and I think as Margie, you mentioned, I mean, healthcare is very broad, and so there are, a variety of segments that have had very different experiences. And rural hospitals, for example, I worked on a restructuring of a semi-rural hospital, but it faced a lot of the issues that I think a lot of rural and semi-rural hospitals faced, which is, a lot of their population depended on Medicare and Medicaid reimbursements. That's slow to get in the door. And so there's already a, sort of liquidity crunch that these hospitals were facing pre-COVID. And then I think, COVID obviously brought a whole nother crisis to bear for many of these places. And it's continuing to unfold, obviously, too, but we'll get there, so.
So kind of segueing off your comments, Genevieve, about liquidity, Karin, you had mentioned that you do a lot of work on behalf of lenders in the healthcare space. What were you seeing in terms of the state of the lending market to healthcare companies prior to the COVID crisis?
Yeah, that's a good question. And as Genevieve and the others were mentioning, healthcare really does cover a wide range of practices, from dental to the practice group management, as well as hospitals, both city types of hospitals, as well as rural hospitals, all of them facing their own unique challenges, and then nursing facilities, skilled nursing facilities, independent living facilities, and assisted living facilities, each with its own challenges. But kind of pre-COVID, each had its own, challenges in the lending market too. But I would have to say generally overall, and as Anne mentioned, I do a lot of work, even on the finance side, for senior and junior and mezzanine and second lien types of lenders. And there was a lot of lending going on, a lot of lending to nursing facilities, to hospitals, especially in connection with physicians, mostly operations changes and things like that, and acquisitions of new real estate and funding capital improvements and things like that. And there was a lot of lending going on. However, as Margie mentioned earlier, there were problems. I mean, the dental field, there seems to always be issues with the dental field that they're facing and the doctors, as well as the physician group practice management. We saw in the last couple of years, similar to what Margie was saying, there have been a lot of issues with that. And a lot of them, you know, the goal was to get as many doctors together into a management group, but it just was falling apart. So it kind of depended on the sector and industry that you're in. But I think overall it was a healthy lending environment. You know, again, certain companies and especially nursing facilities, the margins are low, and so there's always some issues trickling there and need to sometimes shift to a workout scenario. For example, we had a deal where a nursing facility had a company that had been recommending a good referral source that went away overnight. So there were always those types of trips and issues there. But, you know, generally speaking, the lending industry was doing all right. And there are a lot of opportunities out there, especially in connection to refinances and things like that.
I'm curious, actually, Karin, like when in the lending industry for healthcare specifically, did you see a lot of repeat players, or were there folks who attempted to dabble in healthcare, which seems like a daunting task? But I know I've encountered a couple dabblers, which is always interesting.
Well, it's interesting. I think dabblers on both sides. So many lenders over the last couple of years were getting into the healthcare industry. And as we all know, healthcare has so many regulatory issues and requirements that I think some were getting into trouble, not quite understanding what they were getting into, but it was such a hot market and everybody wanted to be kind of in the healthcare. And I think a lot of the lenders, especially those that are new, those are the ones that we'll get to in a minute, that have kind of tightened their purse strings as we've gotten into the COVID situation. Some were doing their, you know, one off and two off. We're doing that kind of pre-COVID. But and then on the other side, there are always, and especially in the skilled nursing facilities, there's always folks that are getting into those types of business. Some of them usually, you know, there's a lot of very large operators that have 100 to 200 types of facilities across the United States. And then there's smaller facilities where they're independently owned, or there's a, you know, a family that owned a couple. And so it really runs the gamut, but there's always those that are trying to get into the business. But it's definitely one of those that you need to know what you're getting into and have some experience. As we've been seeing, those are usually the ones that end up in workout sooner or later.
As you mentioned, you know, not only are there, you know, significant unique regulations in this space, but it almost seems as if they somewhat have their own language. Just, you know, all of the various acronyms.
We could throw in all the acronyms, the SNPs, and there's the UPL, and there's so much going on with acronyms. So I'm trying to actually catch myself that I'm not using the acronyms, but.
So, you know, we've discussed some of the issues that the healthcare industry was facing. There's a lot of money coming into the healthcare industry, a lot of lending. So that seems like a perfect recipe for a lot of restructuring negotiations and potential bankruptcy filings as well. So Genevieve, could you speak a little bit to some of the, you know, kind of key issues you were seeing in either, you know, pre-bankruptcy restructuring negotiations or in actual bankruptcies themselves?
Sure. Yeah. And I think, I mean, it's interesting. A lot of these cases take, you know, many years to unfold. So as we're talking about sort of the pre-COVID situation, we're getting into post-COVID situation. I mean, the Verity case has been going on in California for a number of years already. You know, I think certainly the restructuring issues that arise in healthcare cases could be a panel unto itself, of course. But I'll try and hit a couple high points. I think one thing that I know was an issue in cases that I've worked on recently, and I think based on the literature out there is something that others encounter as well, is the Medicare provider agreement. And again, this is the agreement that allows the healthcare provider to bill the government and collect receivables. And they do this through National Provider Number, NPI. And so there's a lot of debate and sort of focus on whether or not the Medicare provider agreement, which is obviously a really important asset or contract, depending on how you view it and which court is looking at it. But that's the question, is whether or not it can be sold free and clear, as other assets can in bankruptcy, which is one of the big benefits often of structuring a transaction through bankruptcy, or whether or not it has to be assumed and assigned under 365 instead, and as such, whether or not the new provider will have to take all the liabilities with it, which, as I'm sure some of the other panelists can speak to, in terms of the accounting and auditing standpoint, the government's not the fastest in terms of reconciling the receivables and billables. So, you could, if you take an MPI number, if you're a purchaser and you take the MPI number with the Medicare provider agreement, you could be on the hook for years of reconciliations from your predecessor. I think conceivably you could also be on the hook for even fraud. So it's something that, folks need to diligence very carefully and hire the right experts to diligence for them. And, it is, again, an ongoing debate as to whether or not courts should be treating, and the government should be sort of required to treat the Medicare provider agreement as an asset as opposed to a contract, which that's the position that the government generally takes outside of bankruptcy. So that's certainly sort of one hot area. I think, the other thing is that there are certain bankruptcy code specific provisions that relate to healthcare industries. One that is, interesting, is the patient care ombudsperson who gets appointed in a bankruptcy case, in a healthcare case. And, that's a separate section. It's section 333 of the code. And that person's job is to monitor patient care during the bankruptcy. So in my experience, there's a handful of people who do this all the time, and they're often, they have a medical background themselves, as well as a bankruptcy background, but it provides them with the ability to really go into the hospital and monitor what's going on in terms of patient care. And it's just another layer of, it's just another thing to deal with in terms of what your management team has to be prepared to deal with.
And cost.
And cost, yeah, and cost. No, that's a fair point. And the ombudsperson will file a report with the bankruptcy court periodically, and will alert the judge to issues with patient care if and when they arise. And then there's of course issues with nonprofits too that can arise. A lot of the healthcare providers that we see are nonprofit providers. And so, if there's going to be a sale of a nonprofit, there's all sorts of different implications that come into play. So whether or not there are governing bodies, for example, in California, the Attorney General's office has certain requirements that they may impose on the sale or seek to impose on the sale. There's also sometimes with some of these religious, I think one of the religious institutions that I dealt with had I want to say like 40-person board or something. And, you have to make sure, including like a lot of, nuns on the board. And so you have to make sure that what the transaction you're doing is consistent with their mission. And so that imposes sort of additional, issues as well. So I will stop and see. I've been talking for a while. As you can see, there's, sort of a plethora of issues to discuss in these cases.
Sure. Well, I think, we can all unilaterally agree that, the COVID-19 crisis has, significantly impacted virtually every industry, that you could think of. In some ways, maybe positive, but, the majority of them, I'd say certainly it's had a negative impact. All that the healthcare industry is one of the hardest hit. So Margie, would you be able to talk a little bit about some of the specific ways in which both the hospital systems and senior living facilities have been hit hard by this crisis?
Sure. Excuse me. So I'll take hospitals first. It's interesting because one would think that because of all the people that ended up in the hospital, right? That the hospitals would have all this revenue, but in fact, it's just the opposite. There were no elective surgeries, people afraid to go to the emergency room, and they had very, very few people in the hospital other than COVID patients, unless they were, real emergencies, or car accidents or anything like that. And so the revenues, and at first, when I first heard it, I was thinking to myself, this doesn't make sense. They're talking about that they don't have capacity at the hospitals, but they didn't have capacity in ICUs. There's only so many beds that have the necessary equipment to treat the COVID patients. But in some of these big hospitals, I mean, I'm from Boston, and we have some pretty large state-of-the-art hospitals here, and we weren't at capacity, but we were close. However, the rest of the hospital was empty, and they were laying off doctors and nurses, and furloughing people. And you think about it, and you're like, well, it doesn't really make a whole lot of sense, but I guess there was no patients for them to treat. It's the same thing, and I know this wasn't part of the question, but same thing with doctors. Nobody was getting sick. And if you think about it, we're all at home, right? With the exception of maybe going to the grocery store. So germs weren't spreading. And this is, I guess I just never thought about it, because we all go about our daily lives just kind of taking this for granted, right? Kids weren't in school. There was no germs being spread at schools. The kids weren't on the playground, so they weren't falling down off the monkey bars or something and breaking their arm. There was all these things that weren't happening because we didn't go through our daily life the way we normally do. And so that was a huge impact on revenue on these hospitals, without even impacting the fact that they now had to go out and buy all this PPP. Right, sorry, PPE, not PPP, PPE, and make sure that there was enough. I mean, we all heard about the shortages, right? That there were enough masks and gloves and gowns and shields and all that for these healthcare workers to treat patients. And there were shortages all over the place. So all of that impacted, and I'm sure that the cost of those items increased over this time, right? They definitely didn't go down, because as you said, Anne, there were some industries that actually did well during COVID, and obviously that's one of them. I actually heard, as an aside, I heard yesterday on the news that Clorox has increased their production of the wipes by 50%, and they still won't have enough inventory to get out to stores as they had until sometime next year.
Yep, heard the same thing.
I still can't find Clorox wipes. Yeah.
I can say you can't find Lysol in the city of New York.
Yeah.
Nowhere. There's no such thing as a can of Lysol here.
I happened to find wipes a few weeks ago at BJ's, and I thought that I hit gold. I just happened to be there, and they put them out, and I was like, okay, I'm taking them. But anyway, getting back to the question, so that's hospitals and doctors. On the senior living side, again, the PPE. I mean, they were crazy, and I'm assuming that it was the same all over the country. But in Massachusetts, I'm going to say that at some point, I'm going to go back to June, and I haven't been keeping track of it, but more than 50% of the deaths that occurred in the state of Massachusetts were from some kind of senior living facility. They were terrible outbreaks, and they just couldn't contain them. So now the senior living facilities have this kind of black mark on them. No new patients are going in because their families are keeping them at home. And as a matter of fact, some families removed their loved ones because they, when this all started and these facilities started having outbreaks, people went in and removed their loved ones and took them into their home. And, plus they've had many of the residents dying. And so there's lots of empty beds now in these facilities. So it's really hurt them. And, they're still getting the revenue, only, it's less revenue to cover the same overhead.
Yeah.
So
Yeah,
they've really.
Oh, sorry.
Sorry, go ahead.
No, I was just gonna say it's so counterintuitive, because I think, we sort of expect there to be, because of the COVID crisis, a boom in the healthcare revenues, but it just, as you said, has such ripple effects beyond there being more sick COVID patients. There's just, fewer patients in elective surgeries, which I think are some of the larger margin areas for hospitals often. And then, it's interesting, like for my sister's having a baby at a large hospital here in Los Angeles, and usually if you're having a C-section, it's 4 days, but they've taken it down to 2 days that you're allowed to be in the hospital now, because they just want to get everybody out of the hospital. And so that's, of course, a hit to revenue too. It's interesting.
I think it was very eye-opening for me. This would have been back in June when, you were hearing about a lot of the cuts and the furloughs of doctors in these large hospital systems. And I had heard of a friend who was an ER doctor, so front lines for this, current crisis, who received a significant pay cut.
Oh.
It's like, if you are actually cutting the pay of your current frontline, essential workers, things must be really, really bad.
Yeah.
I had the fortune of breaking my hand right in March. And so it was right when everything was shutting down and I had to get some pins in my finger. Anyway, whole long story, but I was the last person, the last day in an surgical outpatient facility to be able to have surgery on my hand, because they were shutting it down because they needed all the PPE, and they just were shutting down, at least here in Illinois, they shut down all outpatient surgical centers. So, everybody that was there had to go home. They didn't have a job for the next, couple of months until they opened them back up again. So yeah, it's interesting how it has affected. And going to the skilled nursing facilities and assisted living facilities, at least here in Illinois, the nurses unions were threatening a strike. And so, not because they weren't getting the PPE that they needed, and there were concerns. And so not only are they dealing with outbreaks in the nursing facilities, as well as, liquidity issues, because the PPP loans and things we'll get to in a minute weren't quite there yet. They were also dealing with negotiations with their nurses union.
Yeah.
And it is kind of ironic, because from where you guys all are versus now I'm in Manhattan. So we started our uptick in March, and we got to our 400,000 some odd number. We had to have the USS Comfort come up, which ironically only housed 19 people, because at first they wouldn't permit anyone who had COVID on the ship. The government wouldn't permit it. So we were like, well, that was the whole point of needing the ship up here, because we don't know if we have enough beds, and at the rate we're going, we're going to need 200,000 beds basically, because watching the news, you would have 1,000 new, 1,200, 1,300, 1,500 new cases every single day. And in New York, we had amazingly wonderful healthcare workers that came from other parts of the country. They called back people that were retired. They allowed people that were in medical school that were not quite, graduates yet, or just were about to start residency, to come in already to the hospital. So it is kind of that twist. And one of the things that ended up being a positive, at least for the New York metro area, was the fact that without the elective surgeries, at least other wards could be converted into COVID centers. They could isolate COVID patients in other places, because there were 19 other patients that didn't have COVID, basically. And we had so it is a little bit unique to hear the perspectives of what were happening in other states, because we experienced our outbreak immediately, and it was just wildfire across the New York metro area, at least.
Well, I guess given the significant impact, basically turning this industry kind of upside down, the federal government then did step in to help. So Karin, would you be able to give us kind of a brief overview of some of the measures that the federal government implemented to assist the healthcare industry in this crisis?
Yeah, happy to. Thanks, Anne. And I'm going to do very brief because there are a million, I'm sure even folks on this webinar have been to other webinars about the PPP programs and all the different programs. So I'm going to give a very high level overview. Happy to answer questions too, but there were, yeah.
Jump in, that totally reminds me, I never said anything at the beginning to audience members. If you have questions, please use the Q&A feature on Zoom, and we'd be happy to address any questions that people have.
Thanks, Anne. So there were quite a numerous, I mean, the federal government did jump in as quickly as the federal government could. So generally by the end of April, they were trying to get some money out in the forms of various relief packages and programs. And quite a few were pointed and directed just solely at the healthcare industry. One, although this was provided to all businesses as a whole, but a lot of the healthcare businesses, especially the skilled nursing facilities and assisted living facilities and the smaller businesses, took part and took advantage of the Paycheck Protection Program, which was recently amended too. But again, there's been a lot of information that's been provided in connection with this, but it's essentially a business loan that can be forgiven if the loan proceeds are used in appropriate manner for paycheck and payment and payroll to employees, sometimes for rent and things and mortgage payments and things like that. And there's been a little bit of morphine and some revisions as the coronavirus has continued on. For example, they originally were requiring applications for forgiveness to be submitted within 8 weeks after the first loan was received, but that's now been extended. So that's an ongoing process, but a lot of, especially in these smaller areas, smaller hospitals, smaller nursing facilities, they were able to get loans, and they varied honestly from a couple $100,000, $700,000 to a couple $1 million of loans from the Paycheck Protection Program. Another that a lot of the healthcare facilities were able to take part of, and that's still ongoing, is the CARES Act grants that is provided by the U.S. Department of Health and Human Services. And I was just looking and on their website too, just to see if there's any updates. But this was a large program that they were giving up to $175 billion to hospital and healthcare providers. And it's been done in kind of waves. They started in April, end of April, beginning of May. Then they kind of got out to the kind of front line, those hospitals and nursing facilities that really needed the money. And they provided quite a lot of money. There's a timeline that's amazing on the HHS website that describes what was given to the different segments and different sections of the industry since April. And they just announced last week that there's another, let me make sure I get the number right, but I'll find it in just a second. But they just announced, there's a press release last week that they are providing another $5 billion to nursing homes that will be available at the end of the month. So they're continuing to make sure that the nursing homes and the hospitals have sufficient funds because of the problems that were just mentioned. And the wonderful thing about these are, as long as you have provided correct information, the providers have provided HHS with accurate information, they do not have to be repaid. These are grants. At the beginning of the coronavirus outbreak, CMS, the section of the government that provides the payments under Medicaid, Medicare, they also instituted what was called the Advanced Payment, Medicaid Accelerated Advanced Payment Program. We call it AAPP for short, and I'm going to use that acronym because the other one's a mouthful. But at the beginning of April, they were able to send out advanced payments on Medicaid reimbursements. And so rather than waiting a couple months for the reimbursements to come through, hospitals and nursing facilities and other providers were able to get advanced payments there. However, the problem with these, and we'll get to it a little bit later too, and how the lenders were dealing with it, the problem is that they need to be repaid, and they were going, and in fact, Medicaid and Medicare and CMS is recouping 120 days after these payments were made. So we're in that portion of time where the recoupment is taking place. So as things wound down, you know, as coronavirus and the federal government got more involved and were able to allocate more funds to the healthcare industry, those that were participating in the AAPP program actually dwindled. In effect, CMS put on their website that they kind of slowed things down because they wanted the providers to be able to look to the grants and to the PPP money first, and then look to the AAPP money. There were a couple other things I'll just touch on. One is deferment of payroll taxes. There's the ability to defer payroll taxes from March until the end of the year. For 50% would be paid by the end of 2021, and then 50% by the end of 2022. But again, those there have to be repaid. So I think, at least in my experience, most of the providers were looking towards the grant and the PPP money that could be forgiven and wouldn't need to be repaid. There's a lot of discussion too about this Main Street lending program that has come out over the last month or so. Interestingly enough, though, there's not a lot of lenders that we have seen, even throughout our firm, that have been participating in that. So it'll be interesting to see, as things continue to take shape, if that is a source of funds that people will really be looking to. Again, the lenders that we've talked to just haven't really been interested in making loans under that program yet. But that's just a general overview. Again, happy to drill down on anything if there's questions.
So it sounds like, you know, there's a lot of money coming in, particularly from the federal government, but has it been enough? So Michele, would you be able to discuss, you know, kind of the current liquidity situation for these hospital systems and nursing homes? How has that been impacted kind of beyond this kind of inflow of money from the federal government?
Well, yeah, and actually, I mean, the liquidity actually ties back to what both Margie and Karin were just saying. So, I mean, obviously on a whole, it's really kind of a mixed bag of responses, because it depends on the type of healthcare provider you are. So, for example, again, hospitals, large hospitals, skilled nursing facilities, doctors, dental practitioners, other types of practice groups have always historically worked on a pretty thin margin to begin with. So now, as Margie pointed out, you have no elective procedures or no non-critical care procedures at a hospital, which suddenly means that although Medicare and Medicaid is a consistent payer, it's a consistent payer that is 4 weeks, 6 weeks, 8 weeks down the road. And we'll set aside the fact again of the fund, the $175 billion. So the higher revenue ticket items are generally, you know, your insurance and your private pays, which obviously are not coming into the hospital for whether they're permitted or not. People also don't want to be in a hospital having certain procedures done because they don't want to risk what else they're going to be exposed to. So you have that from a hospital point of view, but you, as we said earlier, you have absolutely no reduction in really the cost of operations. The demand for PPP, as well as with personal protective equipment, in case we didn't define that earlier, and other types of equipment such as ventilators or such hardware type of equipment suddenly increased dramatically. So obviously there's a premium that's all of a sudden being charged on that. As I said earlier, New York, they talked about how N95 masks were usually 80 cents a mask, and the price went up to the state of New York to $3.20 a mask. So, I mean, that type of thing. And it's part because of, it was also a global demand. This is not just a demand in the US, it was a global demand, and a demand of being able to source it from wherever it could be sourced from. You also had increased employee costs, whether or not, and I get the idea of the furloughs, but you did have to increase the number of physicians, doctors, nurses, cleaning crew that were on a daily basis in the facilities, ICU coverage, potentially bringing in temp employees or employees from other areas. Skilled nursing facilities similarly had the same increased overall operating costs, demand for staff and facility maintenance compliance, coupled with now they also have an inability to bring in new patients. There was even, I believe the state of Virginia governor even announced you should take your parents or your loved ones out of nursing homes at this point to protect them. And then you have the private physicians, practices, dentists, any other healthcare that is strictly shut down. I mean, completely and utterly, there is no income coming in. But again, there is no income coming in. They have to now kind of pivot to see how else they can bring in money. For a lot of doctors, they said, we'll do telehealth type of, we'll do online health. But now that means building up a bit of that infrastructure to get online in terms of privacy and other issues, because you still can't avoid the HIPAA rules or anything else about how you're dealing with patients. So all that said, to Karin's point, then $175 billion gets released. And lo and behold, that provider relief funds through the Department of Health, as of July, I know by the end of July, there was roughly 110 to 115 billion that had already been released. An additional billion was earmarked in March for coronavirus preparedness and response and Families First Acts. And that was doing specifically for the treating and testing and or treating of uninsured individuals. So obviously, again, that brings into play what we said earlier about how a lot of patients now coming into hospitals don't necessarily have full healthcare coverage, or may be subject to just Medicare or Medicaid. Again, though, you have strained states, so Medicaid's not paying quickly. And these payments are meant to mitigate lost revenue while allowing for the entities to continuing functioning. But ultimately, that still does mean a reckoning. And that reckoning, although they are grants, to your point, Karin, they're almost like conditional grants, because the HHS said, they're not loans, they don't have to be repaid, but there are certain conditions for you being able to use these funds, and you have to prove to us that you used those funds for, here, you tracked your losses of income, you tracked your expenses, and they are COVID related. So, your regular expenses of having a problem with your parking lot isn't going to be covered by that, although you might have had to expend something to fix the parking lot. So the need for astute record keeping, keeping track of your payroll, the costs incurred, revenues lost, kind of also puts a bit of pressure on a company, because do they want to mingle all the funds? Do they want to treat something as restricted cash and not use it if they're not using it for certain purposes? There was also the suspension of the 2% Medicare sequestration from May 1st to December 2nd. And that is basically a 2% reduction in Medicare rate reimbursements. It was put in place about 7 years ago now, I believe, in order to deal with the national debt ceiling. Obviously, that's kind of not an issue at this moment with the amount of money that is being spent, but they also instituted a 20% increase in certain Medicare payment for COVID-19 rates. And several states have increased their reimbursement rates. But again, all these payments through and use of funds need to be seriously tracked, and they're going to have to be seriously reported, and payments are going to be need to be made back. And part of that concern, I think hospitals can request up to 6 months, doctors can request up to 3 months of money, and the repayment can be for up to 7 months for doctors and 1 year for hospitals. But we're in month 5 of these funds, so obviously they have to extend these programs because that money is running out from what was first out there. We don't know how much each additional tranche of money can be. And the repayments, and as Karin put it, the advances that are being made are just that, they're advances. So a lot of entities are flush with cash today, or will be flush with cash through the end of August, but they're not going to get those fundings in. And as Genevieve had said earlier, things like the transferring of licenses and stuff, I saw that the hard way on the senior care case last summer that I worked on. It then takes you 6 months to get the funding for what's been transferred. So if there is activity going on right now, Medicare and Medicaid hasn't completely fixed their issues with the last change in reimbursement rates and hasn't completely reconciled that yet. Now they're going to have yet another reconciliation process to go through. So entities don't really know what they're going to be faced with 6 months down the road when suddenly they get told all of what had been your diagnostic related groups, we've kind of shifted again, which is, by the way, in July, or in June, I believe, Medicare released their new IPPS. It is, I always lose the acronym, Inpatient Prospective Payment System. So they released all their new rates, basically. And those rates, once again, mean everyone has to go back to the drawing board to see how they're coding things. Again, just adds another layer of complexity to dealing with these funds.
Sure. Well, Karin, how are you seeing the lenders respond?
That's interesting. I mean, just going back to what Michele is saying, the lenders do understand that even though the grants are, people are viewing them as grants, they do need to be tracked. And even on the PPP loans as well, there's a lot of tracking that needs to happen. And so lenders are essentially, of course, the borrowers were coming to lenders, especially in April, mostly April time period in May, looking for extensions, and they were going to have issues, and they saw covenant violations coming up. And so a lot of them were proactive and went to their lenders to talk about how to deal with these issues. And the lenders were going back and revising credit agreements to ensure that there's specific reserves now put in place, especially with the advanced payment program for CMS. And then making sure that if there is an obligation, there's a lot of reporting and notice requirements now that lenders are putting into their loan documents to ensure that if they do need to repay any of these CARES Act grants from Health and Human Services, that they are immediately notified and a reserve is put in place. So they are working through their credit agreements to ensure that their collateral is protected and to ensure that there's sufficient, liquidity and from the lender's perspective to ensure that if something does go south, if there's recoupments, which are going to happen. I mean, if there's money that's due and owing, the first thing the government usually does is recoup. So they just need to ensure that they're protected in connection with recoupments from government. Because the lenders, most lenders, at least in the healthcare industry, to the operators and to providers, are lending on accounts receivable, and they want to have a first lien on that. But if the government can recoup, they essentially take the lien away from the lender. So there's a lot of concern from the lender's perspective on how these programs are going to play out. And they have been and tried to be, I've been on numerous calls with lenders, trying to think through where the risk is and how they can best solve for that. And even, getting minute and granular, lenders are also looking at financial covenants and how they're being calculated, because a lot of, especially on the PPP loans and grants, those could be, under GAAP, they're deemed to be income, if they don't have to be returned, but they're extraordinary income. And so the lenders want to make sure that they're taken out in some covenant calculations and things like that. So there's a lot of different areas that they're working through, and how, another, just going back to the personal protective equipment, the PPE, how the expenses are being coded too and calculated in connection with financial covenants. So there's a lot going on in the loan documents themselves, and the lenders that the lenders are thinking about, and some of them are staying up all night worrying about. So I think that was more at the beginning, and they're now kind of sitting back and watching to see how things are continuing to play out. But it's definitely been interesting, because as things have been moved, there's some banks that we've been getting calls from that have set up new special asset groups, new workout groups that are just COVID related, because a lot of these businesses were doing fine pre-COVID. And so it's not that they necessarily want to kick them out of the bank and get them to refinance. And even if they did, there's just not a lot of refinance opportunities out there. So they're trying to manage how to deal with these loans and kind of put Band-Aids on them for the time being, hoping that things will turn around at some point. But it goes again to the level of just uncertainty. As we all sit here right now, we don't know when this is going to end. And, the lenders have talked to their borrowers about putting together, 13-week cash flows and things like that. And I was talking to one lender the other day, and she said, I got a call from my client, and they said, their customer, they said, yeah, I can put together a 13-week cash flow, but not going to be right, because I have no idea what
can't count on it
in the next couple of weeks. So it's just that level of uncertainty that everybody's dealing with right now, and that's felt throughout the globe generally, but definitely throughout the healthcare industry and the lending industry.
Karin, are you seeing lenders just totally, I guess I don't want to say ignore, but ignore covenants?
I have seen a lot of waivers and allowing, or, you know, when you say ignore, most of them are willing to, yeah, most of them are willing to work with the borrowers if the borrowers come and talk to them. When it's kind of at the end, you know, where there's been a covenant violation and they haven't talked to the lender's a little more leery on kind of waiving. But a lot of them, if they're coming and being proactive and talking to the lenders have even said, you know, you don't need to comply with this covenant for the next couple months for some period of time. But again, it kind of depends on the type of borrower it was pre-COVID. If they were already having issues, they're a little more leery to do those types of waivers and things like that. But if it's just COVID-related issues that they're grappling with and problems that they're having, I have found that the lenders are dealing with those differently.
So I guess we've got, you know, just about 10 minutes left or so. I think we'll pivot a little bit from what we had initially planned. And I think what I'd like to do is if we could go around the panelists and have each one talk about, you know, what your thoughts are on some of the, you know, kind of key long-term impacts of this crisis on the industry, the healthcare industry as a whole.
Yeah, I'll go ahead and start. I mean, one thing that I think we're only beginning to see, at least from sort of the lawyer's perspective, trickle in is litigation. And so, you know, I think there's going to be a variety of litigation over, you know, what is, for example, in the SNF context, you know, what the standard of care was with respect to patients and COVID. I think we're going to see litigation arising, and I think we've already seen it come up with respect to employers requiring employees to go back into work and whether or not they did have in place the appropriate PPE. So I think, you know, ongoing litigation is going to be a legacy of the COVID crisis, unfortunately. And then I also think from an operational standpoint, and I'd be curious to hear the other panelists' thoughts on this. I mean, I think there's going to be a big boom in telemedicine because I think it's been beneficial for patients and doctors. People have liked using it. I mean, I've, as a patient, liked using it. I've heard doctors have liked using it. And so I think as we go forward, there's going to be a lot more telemedicine and, you know, healthcare and providers and insurance companies, everyone's going to have to adjust to how they, you know, bill for that, how they seek reimbursement for that, and, you know, what that's going to look like from an operations standpoint.
I think that, I'll jump in. I think that we're in for a long ride. I don't think that this is going to change anytime in the near future, or at least this liquidity issue, the covenant issue, all that stuff, because until we get back to normal, whatever the new normal may be, I think this is a long ride. I also think that we're going to see a lot more consolidations, whether they're mergers, acquisitions, whatever you want to call them, but there's going to be lots of transactions out there because there's going to have to be some more consolidation and more reduction of overhead expenses.
I'll jump in next. I think to Margie's point, I think that we have to first, the way healthcare operates going forward, there's going to have to be a new normal, even defined. And I think that's going to take, to Genevieve's point, there's going to be a lot more investment from both a company point of view as well as honestly businesses that are going to rise relative to telehealth and data management and data transmission electronically. I know that's another part of some of the ways to capitalize on the new DRG rates, for example. So companies are going to have to, and healthcare entities are going to have find innovative ways to reduce their expenses, enhance reimbursements, and kind of build into their models the when things kind of change. You know, how can we use our space better? How can you lay out your facility better, like a nursing home? You know, how can we just lay out rooms that keep people separated better, or ICUs, or do we have available beds that we can use in a different or a different way? How do we increase the ability for visitors to come in safe environments? Because again, a lot of that comes back from both the reimbursements. But I do think that one of the biggest industries, and I just read an article recently, the U.S. healthcare virtual reality, which to me still sounds a bit astonishing that you have virtual reality in healthcare. It was a $101 million business, or it's a $100 million entity, I guess, operation in 2020, and it's estimated to grow to roughly 370 to 400 million by 2024. So, I mean, there's obviously going to be a lot of investment in a lot of, I guess, more adventurous and out of the box thinking type of healthcare delivery.
Yeah, and just on the restructuring bent, I think, based on what we have seen so far, clearly there are issues that the healthcare industry is facing. The federal government has jumped in to try to bridge the gap and help with liquidity issues to ensure that patients are being provided for and there's money to pay the employees to ensure that they're coming to work. And then, it all goes back to patient, ensuring the patient is healthy and safe. But I think, as somebody had mentioned and alluded to earlier, there is going to be a day of reckoning, right? I mean, not everybody is using the money appropriately, even though they're trying. I'm sure there's going to be some issues, and money is going to be need to be repaid. And kind of just setting that aside for a second too, because of all of these different programs that were out there, some of them were actually conditioned on certain certifications that the company was not planning to file for bankruptcy, that they weren't in bankruptcy. And in fact, we've heard of one company, one nursing facility that had filed for bankruptcy and then dismissed its case so it could get a PPP loan and then refiled for bankruptcy again. So there's a lot of different things that that companies are going to be dealing with. And I think we're on a cusp, but again, the uncertainty is still there. We are on the cusp at some point in the next, who knows, a couple months, even a year, depending on how long this takes and how long the government's able to buoy up this industry, that we're going to see a lot more restructurings. I just feel that coming on as well. And that might be part of the mergers and acquisitions too, that the opportunities that come up in connection with that, there are going to be a lot of distressed types of acquisitions that are going to be out there.
Yeah, I think that's exactly right. I mean, I think this is sort of, the beginning. I mean, we're sort of all the beginning of the cycle, and obviously there's been plenty of filings, already, and in healthcare and outside of healthcare, and a number of companies have sort of used the COVID cover as the excuse for the filing. But I think really we're seeing, the weak ones sort of falling first, and the true impact of COVID in terms of the restructuring industry, I don't think has been seen yet. And I think is going to take, some time to play out because of this liquidity infusion and sort of prop up by the federal government.
Yeah, I think I agree. Once the companies all have to start paying things back, you're going to get to the month of October, November, December, when, God willing, a vaccine is out there and suddenly things kind of get a little bit more normal. That's when all of a sudden those that weren't doing well beforehand or didn't really address their issues appropriately as quickly as they should have, that's when you're going to kind of seeing the break in which companies just can't go on much further and they'll fall behind, and then you'll have a across the industry, across the board.
All right. Well, thank you very much, ladies. This has been a great discussion. And big shout out to Sherry, as always, for making sure everything went smoothly for us, and for all of your help in getting this set up. Sherry, I believe, will be posting the video recording to the IWIRC YouTube channel. So if anybody missed, who had signed up or was interested but couldn't log in today, it will be posted online so people can go in and catch up later on this discussion. So thank you all so much for participating, and have a great rest of your day.
Thanks for having us.
Thank you.